Hi, you guys. I want to talk to you about fetal monitoring. When we go to the hospital, we're constantly monitoring the baby, the whole labor, because we know when the uterus contracts, at the peak of the contraction, there's no oxygenation to the baby. So we have to be very mindful of the fetal heart rate to make sure that everything is okay. So there's three basic principles for evaluating a fetal heart tracing. One, the fetal heart tones, which is the top of the strip. Let me show you that. So you can see here's a strip. The top is the fetal heart tones, and the bottom are the contractions. Okay? So we're going to evaluate the fetal heart tones. They should be 110 to 160. 120 to 160 is the norm, but if they've always been around 110 to 120, that's okay. We want to look at the uterine contractions at the bottom of the strip, and then we want to see, do the contractions have anything to do, or what is the relationship of the uterine contractions to the heart rate? Do the contractions make the heart rate change? And that's really important. So you guys, variability. So the best way for me to describe this is like, when you see a cute person that you may be interested in, you know how your heart kind of flutters and your heart rate goes up? Well, that's because you have your sympathetic nervous system. It makes you excited and it causes your heart rate to change. Well, that's the same thing with the fetal heart tones. As if the sympathetic and parasympathetic nervous system is intact, you will see variances of fetal heart rate. So the baby sleeps about 20 minutes out of every hour, and we can have decreased variability, which is 1 to 5 beats. Average variability is that we see the heart rate change from 6 to 25 beats per minute, and that's associated with positive fetal well-being. And then marked variability is greater than 25 beats, and this is like, when someone's doing drugs or they're having some kind of acidotic problem, how their heart rate will vary up and down, and that's not good. And then of course absent variability, no variability, is very, very ominous. So we can look at it here. Undetected, this tells us that we have a brain dead baby, that we're having a lot of trouble. Minimal variability, greater than 1 to 5. This says either the baby's sleeping or we may have some problems, we just don't know. Average or moderate variability is what we want. We can see that the brain is causing the heart rate to change. And that's 6 to 25, and that's great. And then marked variability is greater than 25. And we know that this could be acidosis, it could be drug withdrawal, it could be a lot of ominous features. So we don't want that as well. This is the one we want, is moderate variability. Now the uterine contractions. So the uterus, of course, contracts and pushes the baby out, dilates your cervix. You want contractions every 3 to 5 minutes, lasting 45 to 90 seconds. And so here's the anatomy of a contraction. So it's the increment when it goes up, the acme, which is the peak, and then the decrement. The duration of the contraction is from the beginning of the contraction to the end of that contraction. We want this to be 45 to 90 seconds. And then the frequency is from the beginning of one contraction to the beginning of another contraction. And we want those every 3 to 5 minutes. So these contractions are needed because that's what pushes the baby out. We love them. But do you see these intervals of relaxation? This is where a baby gets reoxygenated. And this is because when the uterus is relaxed, the endometrial arteries open and provide oxygen and nutrients to the baby via the placenta. You can see at the peak of these contractions, there is no blood flow into the uterus. So that means nothing can go to the gap. So baby's not getting any oxygen or nutrients in these gaps, in the gap during this period. So while contractions are needed to push the baby out, we also need relaxation. Sit by the pool, have a nice Diet Coke and some nachos. So you get oxygen, relaxation, food during this time. So if we have too many contractions, we can have decreased oxygenation to the baby, which will result in acidosis. Or too long of a contraction, that can happen. So now when we look at the relationship of the contraction to the fetal heart tones. Oh, and the last thing is we want our fetal heart tones, let me go back up here, to be between 110 and 160, 120 to 160. That is of utmost importance. Now let's look at the relationship between the contractions and the fetal heart tone changes. So whenever we see U, V, or W shape, irregular decelerations in the fetal heart tones, we know that there's compression on the cord. So the baby could be laying on it. So of course, if the baby's laying on the cord, all we're going to do is turn the mom. I mean, easy peasy. Change positions. And if it's really bad, if they're really deep like this, we may give some oxygen. We may put some fluid in, some amnio infusion to float the cord up. And if we have Pitocin running to cause these contractions, we may stop that. But this is the normal intervention. These are the normal interventions. Just turn the patient, and if they're really severe, give some oxygen. Early decelerations. So when we talk about decelerations, we're talking about at the peak of the contraction. So you can see these are the peaks. So when you're looking at a strip, you always want to look at the peak of the contraction, and you want to see when did the deceleration start. Did it start before the peak of the contraction? And we can see that these did start before the peak of the contraction. So they actually mirror the contraction. You can see it down here. So when the contraction started, the heart rate started going down. And you can see that was before the peak. These are good. This just indicates head compression, which is a good sign. It means that the baby's head is being squeezed, is molding, and moving down for delivery. And there are no nursing interventions. We love early decels. Late decelerations are very, very, very bad. So we can see that here's the peak of the contraction. And remember, they don't get any oxygen here. So what this shows us is decompensation. So they didn't get any oxygen, and now their heart rate went down. This is really bad. Same thing here. Now their heart rate went down. Look at this one. So here's the peak of the contraction. And now their heart rate is going down after the peak of the contraction. So you guys, it's very, very ominous. It is not good. That's called uteroplacental insufficiency. Either the uterus is not getting enough oxygen, or it could be getting enough oxygen, but the placenta cannot get it to the baby. So it's either the uterus or the placenta is causing us insufficient oxygenation to the baby. Very, very ominous. Very, very bad. Most of the time this happens when the placenta is damaged and there's decreased perfusion. The causes of this are vascular problems with the placenta, smoking, age of the placenta, post dates of the baby, drugs, diabetes, hypertension, or hypotension. So what are we going to do to stop this to help our baby? So change positions. Of course, we're going to see maybe is there some compression on the placenta. Turn off the Pitocin if the Pitocin is running. That stops contractions, so theoretically it should stop these decelerations. Give O2 via a 10-liter non-rebreather to get more oxygen in mom, to get more oxygen to the gap. Give an LR bolus, a lactated ringer bolus, to increase the pressure, the vascular pressure, to push all of that oxygen over to the gap. And notify the physician if we can't correct it. And we need to have a C-section because we could have very ominous outcomes. So this is how they worked, and I kind of talked to you about that. This is what you have to remember for your test, veal chop. And you're going to know that you're going to have this on the state board. They always get this on the state board. Variable decelerations or cord compression. Turn the baby. It could be oligohydramnios, not enough amniotic fluid causing the compression. So turn the mom. Early decelerations is head compression, and that's okay, that's good. Accelerations or elevations in the fetal heart tone are good. It means good fetal oxygenation. And late decels are placental insufficiency, and we have to do all of our interventions. So you guys will many times say that we need to, this is on the nclex category 1 tracing, category 2 tracing, and category 3. 1 is good. Everything is great. Moderate variability, we know that the heart and brain are working. The baseline is 110 to 160. There's no late or variable decels. And early decels can be present, which is fine. And accelerations, which are really good, are there. So it's related to normal, natural, good base. Intermediate is not predictive. It's not predictive of abnormal fetal acid base, but we got to monitor really closely. So it doesn't fit this criteria. It's not fitting this criteria, but it's not fitting this criteria. So category 3 is predictive of abnormal acid-base balance. So acidosis related to decreased oxygenation. So absent baseline variability. So that's where there's no change. So zero variance in the heart rate. Recurrent late decelerations, always very bad. Recurrent variable decelerations that are deep, or bradycardia, which is low heart rate, less than 110, or a sinusoidal pattern. And this is what a sinusoidal pattern looks like. It's this wave. It just looks like these waves that look exactly the same all the time. It's related to severe anemia and hypoxia. So you guys will take your fetal heart simulation quiz after you watch this, and this should help you to get that done. Thank you.